Thoracoscopic which is voted by Sriram and to begin with, I am going to the president, the madam here. And welcome to you all people. Let's start the program today. We have 6 posters and 6 papers. We have Dr. Shahnawaz as a judge for the poster, Dr. Karthik and Dr. Nida for the papers. Now I hand over the stage to Dr. Sriram, the Intruder of St. Martha's Hospital, to conduct the program. Sir.
Thank you, Dr. Prem. Thanks one and all for coming here and on the Zoom meeting of ours. We have to start with the poster. The poster initially starts 5 minutes. 5 minutes. After 4 minutes, they will get well. Then 1 more minute will be there. Then after end of the 5 minutes, the poster will be over. So the first poster, we have got a unusual case. It depicts upon a volvulus. Why? It is an infant age group that is depicted and presented by Shahnawaz. Go to Yoshida.
Good evening, everyone. The poster for today is Pediatric Gastric Volvulus. Yeah, well presentation. So we had a Lamania female present to a casualty with shock. When we received her BP.
If I can interrupt you just a little bit, there's a little echo that seems to be coming. So you're not very clear. Your voice is not very clear. There is an echo from your end. I wonder whether it's happening because multiple systems are on at the same time.
Am I okay now?
Little better. Go ahead.
Sir, go ahead, sir.
Yeah.
So we have a pediatric gastric volvulus with a rare case presentation. So we have Lamania female presenting to our casualty with shock. When we received the patient, she had a tachycardia pulse rate of 144 beats per minute, and her pulse was recordable. After fluid resuscitation, her BP was recovered to 100 by 60 millimeter of mercury, and the history she gave was an abdominal pain since 2 days, and multiple episodes of coffee-colored vomiters. So we went on to assess the patient. After post-assessment, we introduced a RILES tube for due to multiple episodes of vomiting. The RILES tube was an easy insertion without any resistance. Followed by the RILES tube insertion, we went on to take an X-ray, chest and X-ray abdomen. In between, our investigation was done with an raised glucose response and you are showing 128.6. So the X-ray showed a free air under diaphragm, and X-ray abdomen erect and supine showed a surprise in presentation of RILES tube over the left iliac fossa. So with this presentation and with this X-ray and we had location of our RILES tube, we went on to do a laparoscopy, keeping in mind this free air diaphragm could be a duodenal or a gastric perforation. But to our surprise, here's a short video of a laparotomy where we happen to see a gangrenous part of the greater curvature of the stomach presenting with a perforation, and thus says the weird location of our RILES tube post insertion, where the RILES tube has come off through this perforation and was in the left iliac fossa region. So this is a laparotomy picture of laparotomy video of showing the greater curvature gangrenous region. So this was our interpretive finding, where the gastric volvulus, it was present as a gastric volvulus with the fundus and greater curvature gangrene and the perforation of gangrenous part. We had a dog tube turbid peritoneal fluid also was noted. So these are some of the pictures we have taken intraoperatively, where post-laparotomy we have found it was a gastric volvulus causing the gangrene of the greater curvature stomach, which is ended up resulting in the perforation. The procedure that we went on to do was a partial gastrectomy plus feeding duodenostomy. Post-operatively, patient was doing fine. We started oral diet and PO-Defying after she has postures. So for discussion, so gastric volvulus is defined as an abnormal degree of rotation, where one part of the stomach was around the another. The peak age group of incidence is in the 5th decade, with children less than 1 year old making 10 to 20% of the cases. The possibility of ischemia and perforation is a higher risk in acute gastric volvulus with necrosis, as reported in only 1% of the cases, and the moderate is reported in 50% of cases. So this is one of our cases which presented to us gastric volvulus with perforation. And normally they present with a Bolster's clinical triad of severe epigastric pain, distension, violent unproductive retching, and unable to pass the nasogastric tube. In our case, we were able to pass the nasogastric tube without any resistance. And normally they will also find with a radiological finding where Nisa and antroaxial volvulus, which has a double air fluid level, and organaxial volvulus in the stomach lies horizontally with a single shadow. But we had no such radiological finding where we had only an X-ray finding of air under diaphragm. The management normally or traditionally used to do with an gastroscopic decompression for chronic gastric volvulus, as chronic gastric volvulus presents with a violent retching. So we just go and do a Ryle's tube and empty of the decompressed stomach, or an anterior gastroplexy supplemented with a gastrostomy, or percutaneous gastrostomy, or laparoscopic guided gastroplexy, which are done conservatively, traditionally. But keeping this presentation and this history in mind, we have done a partial gastrotomy with a feeding jejunostomy, which is for a very rare case presentation of a perforation. These are my references, and thank you.
Yeah, very interesting case, Sriram.
So, thank you, sir.
Any idea what is the incidence of gastric volvulus in pediatric patients?
Okay, so gastric volvulus incidence pediatric cases around 10 to 20% of all the total volvulus case presentations.
No, out of the volvulus cases, okay, that's fine.
Yes, sir. Yes.
Out of let us say a child presents to the emergency with an acute abdomen.
Yes, sir.
What is the likelihood of it being gastric volvulus? What percentage?
Out of the acute abdomen, sorry, sir.
Yes, yeah, that's what you had, right? You had a child with an acute abdomen.
Yes, sir. Yeah.
And then you had pneumoperitoneum, so you went and took it in, and you took her up on the table, and then you found this.
Yes, sir.
So just to give a perspective, if you can just give us, is it there in the literature? Did you find it anywhere?
No, sir. I will look into the angle of acute abdomen presenting as and gastric volvulus for the literature prevalence, sir.
Right. Did you consider doing a CT scan for this patient?
No, sir. It was an acute presentation to us. I'm with a free air under diaphragm. So, free air under diaphragm, considering it's an duodenal gastric perforation. So, CT was, I wouldn't say not at best. CT was not
very straightforward.
Yes, very straightforward. It is to go ahead with the laboratory.
The pneumoperitoneum
helped you to go ahead with the laboratory.
You said the urea was 128. That's what you said, right?
Yes, sir. Yes, sir.
What time did the patient present and what time did you operate?
So patient presented to us in the early morning, sir. 37 she presented early morning.
Okay.
But before the 2 days, she has had this complaints of abdomen pain and vomiting.
Right.
Yes, they have taken considerable management outside as well.
The patient came to you at 6:30, right?
Early.
And what time did you operate?
We went on to do the surgery within 1.5 hours. 9 o'clock.
Why would I ask this question? Generally, when we have an emergency laparoscopy setting, one is the setting of trauma, and the other is in the setting of this kind of a peritonitis.
Yes, sir.
Right.
Yes,
so, sir. Is there anything that we give consideration to when we take her up, when we take such patients with peritonitis up for surgery? You said her BP was not recordable on presentation, and then you stated it was 160.
Yes, sir. So unstable vitals would have been a reason not to go ahead, but we were able to resuscitate her.
No, could she have been in shock? Could she have been in?
Yes, sir. She presented to us with shock. She presented us with shock. That's why we hit
with shock and dehydration.
Yes, sir. Yes.
No, a lot of the experienced surgeons would advise you that it's better to just measure out her urine output, maybe give it an hour or two, rather than trying to rush such patients into the OT right away. A dehydrated patient with a proper resuscitation will give us a better outcome than trying to hurry the surgery. That's the point that a lot of our seniors would teach us.
Yes, sir.
Right.
Thank
Anyway,
you, sir. Any more questions, sir?
No. Thanks.
Thank you, Sriram. We'll move on to the next paper. As you know, hernia is a very common presentation everywhere. Here, Dr. Karthik Patel is supposed to present a poster on rare abdominal internal hernia. Over to you, Karthik.
Hi, Karthik. Go ahead.
Good evening, everyone. I am presenting a case of rare abdominal internal hernia. A 43-year male presented to the emergency with a history of diffuse abdominal pain since one day. The pain is sudden in onset, gradually progressive, colicky type of pain, which aggravates on taking food. Patient presented with one episode of non-bilious vomiting containing food particles. Patient had a history of vague abdominal pain on and off since 1 month. Patient doesn't have any history of previous surgeries, no comorbidities, and not on any medications. Coming to the examination, patient had tachycardia of 102 beats per minute. Other vitals were stable. On per abdomen examination, abdomen was soft, fullness noted in the epigastrium, bowel sounds were normal, and PR was normal. Coming to the lab investigation, patient had an elevated total leukocyte count of 11,400 and other parameters were normal. X-ray abdomen pelvis was done and it was normal. Ultrasound was done showing no sonological abnormalities. Patient underwent CECT abdomen pelvis which showed left paraduodenal hernia with entrapped small bowel loops and viable bowel. Patient was taken up for emergency laparotomy procedure which showed defect in the left paraduodenal space, that is foramen of Lancets, with jejunal and ileal loops trapped in it. The bowel was viable. The defect is closed with the observable suture by approximating the mesocolon with the base of the mesentery. Patient post-operative period was uneventful. Soft diet started on post-op day 1. Patient moved his bowel on post-op day 2, discharged on post-op day 3. Coming to the discussion of paraduodenal hernia. First, types of congenital internal hernia are paraduodenal hernia, that is comprises of 30 to 50% and it is the most common. The other hernias are hernia through the foramen of Winslow, pericecal, intersigmoid and paravesical hernia. Left paraduodenal hernia arises from the fossa of Lancets, which comprises of less than 2% of all hernia, and it is 3 times more common than its right counterpart, that is hernia through the Valdez. Then the most common age is the 4th to 5th decade, and with a mean age of 38.5 years. Usually, patients are asymptomatic. It is an incidental finding. Patients may present with diffuse abdominal pain, vomiting, and other features of obstruction and bowel gangrene. Contrast enhanced CT is the investigation of choice. Lifetime risk of incarceration or strangulation is over 50%, with mortality risk of 20 to 50% if the patient is left untreated. Although it is a rare condition, it can cause high morbidity and mortality if the patient left untreated. Treatment is by laparotomy and procedure. With this, I would like to conclude, paraduodenal hernia is a relatively rare cause of acute abdomen. Establishing a clinical diagnosis is challenging and is delayed owing to its variable signs and symptoms. Internal hernia as a differentiated diagnosis is always kept in mind, particularly in a patient present with abdomen pain with no previous surgeries. Thank you.
Wonderful.
Question is for discussion, sir.
How old was the patient, Karthik?
Sir, 43-year-old male, sir.
43-year-old. Would you like to comment on any other operative findings that you had? Of course, you had a paraduodenal hernia. Apart from that,
Sir.
would you have
Dilated bowel loops were there, sir.
Pardon?
Dilated bowel loops.
Okay, dilated bowel loops.
Proximal dilated bowel loops were there, sir.
What else? What else would you look for?
Sir, we have to see the viability of the bowel.
Okay.
And the constriction ring is there or
So
not, stricture is there or not.
How did you decide that the bowel was viable?
Sir, the peristalsis was good, blood flow was good. By intraoperative, the color of the bowel was good on giving 100% oxygen. And that blood vessels through the mesentery was pulsating, sir. So we can tell bowel is viable.
Okay, Dr. Manjunath is asking, what was the procedure done?
Sir, hernia is that from the defect, the viable bowel was reduced, and the defect is closed with approximating the mesocolon with the base of the mesentery, sir.
So, did you close the defect?
Yes, sir. We closed with observable suture. Yes, sir.
Did you look for any other abnormalities, any other abnormal positions. Maybe the cecum was somewhere in the epigastrium, or maybe.
Sir, no abnormalities or malformations seen, sir. Actually, bowel walk was done, sir.
Bowel walk. What is bowel walk?
Sir, visualizing the bowel from the proximal till the ileal to the ileal end.
So what is
to
the
see
proximal
any
end?
structure, sir.
What is the proximal end?
Proximal means duodenal jejunal junction, sir.
Duodenal jejunal junction, and you followed it all the way down to the ileocecal.
All the way down to the IC junction, sir.
Suppose the cecum was in the midline in this patient.
Sir,
is there anything else that you would have done? Of course, you went in, you reduced the hernia, you confirmed that the bowel was viable, you closed the ring. Let us say the cecum was in the midline rather than in the right ileal fossa. Anything else would you have done?
Sir, we should see that for any malrotation.
That's what I'm indicating. If there was malrotation, what would you have done? Any other procedure?
Flats up. Lats band has to be.
What is the surgical price for a first-year resident? As a cutting chance, no, you all discuss yourselves. I'm getting this cutting chance, I'm getting that. Emergency, common emergency.
Sorry.
Would you do an appendicectomy?
Appendix. Yes, correct.
Why? Why? Why should we do an appendicectomy? Appendix is normal, it is not inflamed.
Maybe in future,
maybe
in future patient may develop appendicitis. So as a prophylactic.
See, what happens is there will be a diagnostic dilemma. If the patient develops an appendicitis in the future and the appendix is malrotated, right? It is not in the normal position. You would not normally go and do a laparotomy for everybody, see if they have malrotation, go and take out the appendix. You would not do that, right? But if you find malrotation, go and take the appendix out to avoid such diagnostic dilemmas, right? Thank you.
Any more questions, sir?
I think we'll go to the next speaker.
Thank you, Karthik.
Thank you, sir.
Our next poster would be on adrenal adenoma. Usually, adenomas of adrenal glands. I usually define whatever the basics are given, but here is a case. We define the basic, whatever is there as adrenal adenoma. Dr. Vandana is going to present on adrenal adenoma.
This is very interesting, right up my alley.
Over to you, Dr.
Yeah. Yeah, go ahead. Go ahead, doctor. Hi.
Good evening, everybody. Today, my poster is about adrenal adenoma, defying the basics. So here we have a case of a 35-year-old female patient with right flank pain on and off since 3 months. She also had intermittent headache and sudden episodes of sweating for 3 months, and she had no known comorbidities. On examination, the patient's BP was taken on both sitting and standing positions, which was recorded to be 120 by 80 mmHg. Also, per abdomen was soft. There was a palpable mass in the right lumbar region, which was bimanually palpable. There was minimal tenderness present. So on investigations, we went for an ultrasound abdomen and pelvis, where the right renal fossa mass was arising from the adrenal gland with hypo and hyperechoic features. The mass was measuring about 12 centimeters. So we also sent for routine investigations where everything was found to be normal. So on CT, what we found is we have a coronal section, we have a sagittal section. So there's a right adrenal mass lesion, which is surrounded by a capsule, and the inferior vena cava is getting compressed. And also there is abutment of the right lobe, inferior surface of the right lobe of the liver. And also the renal vessels have been, were getting compressed. And the mass was found to be about 11 centimeter. So these are my CT findings. We also sent for functional assessment where the metanephrine and the non-metanephrine levels was within the normal limits. So the procedure plan for this patient was a right open adrenalectomy. And we prepped the patient before by recording the BP on sitting, standing, and lying down positions. And also the patient was started on alpha blockers 7 days prior to the surgery. Also, we increased the hydration level to 3 to 4 liters per day. And there's also an increase in salt intake for about 5 grams a day. Also, the patient was started on beta blockers 2 days prior to the surgery. And during the surgery, we had absolutely no BP fluctuations. And post-operatively, we found a large mass, encapsulated lobular mass in the hepatorenal pouch, which was measuring about 13 into 13 centimeter. And there was the right renal vein was stretching and was over the it was entering the inferior vena cava, and the mass was pushing the right kidney below and covering almost 2/3 of it. So on a histopathology report, the right adrenal gland mass showing features were consistent with adrenal cortical adenoma. We also sent for immunohistochemistry, where synapto-5-sen EMA and key 67 melanin inhibin markers were taken, and they were all, it was a negative report. And so coming to the discussion, based on the CT findings, the prevalence of incidentalomas are somewhere between 0.35 to 1.9%. And according to literature, adrenal tumor size of greater than 4 centimeter has high sensitivity to adrenal cancer. And also, in our case, in this case, though the tumor was about 13 centimeter, after IHC evaluation, irrespective of the functional status, and after prepping the patient and after the pre-op evaluation, it led to a smooth surgical outcome. So hence, this is about my case.
Yeah, congratulations on the case. Congratulations to your unit.
First is for questions.
Thank you.
Yeah, many congratulations to your unit again.
Thank you.
And you said you got the patient with a right iliac fossa mass, right? There was a right flank mass.
Yes.
Mass in the right flank, and then you did an ultrasound, and then you went and did a CT.
Yeah.
When was it that you kind of doubted that it could be from the adrenal? Was it when you examined the patient, or was it when you did the ultrasound, or was it after you did the CT?
When we did the ultrasound.
So when you did the ultrasound, you kind of suspected an adrenal mass,
yeah,
right?
Yeah.
Okay. Would you, let us say you get another patient like this,
okay,
would your management be the same? Would your steps of investigation be the same?
Yes.
Or would you do something different?
No, initial investigations would be routine blood investigations, and also an ultrasound, and then a CT. And then based on the report, like CT findings and the ultrasound findings, we'd change the further management.
Anyway, let me tell you, whenever it's endocrine, no, be it thyroid, be it adrenal, more so in adrenal, the functional diagnosis takes precedence.
Yeah.
It's the functional diagnosis that is important. Once you establish that it is a functional tumor or a non-functional tumor, you address the function. If it's a functional tumor, see whether it's a medullary tumor or a cortical tumor. Why is this so? Because suppose it was a pheochromocytoma. Just the simple act of doing a contrast enhanced CT would have pushed the patient into adrenal crisis, right? Which is why anybody with a suspected adrenal tumor always gets a functional assessment first before anatomical characterization, right? Okay, that's point number one. You said the patient's BP was normal.
Yeah.
Would it still have been pheochromocytoma with a normal BP?
Usually in pheochromocytoma, we see fluctuations, heavy fluctuations of BP.
Okay, okay.
Like this paroxysmal hypertension is seen a lot.
Usually we see that. What about unusual? Okay, a lot of textbooks tell us about the 10% tumor, isn't it?
Yeah,
Pheochromocytoma is a 10% tumor. So 10% of pheochromocytomas can be normotensive.
Normotensive.
It's a little higher. It's not 10%, up to about 15%, 12 to 15% in the recent literature, right? So such patients with pheochromocytoma have been found to be normotensive. There's no hypertension. So simply because the patient doesn't have a high BP, that itself will not rule out a pheochromocytoma. Okay. Now, the other thing you said, you have a 12 centimeter tumor, which is, you're correct. Such a large tumor being benign is very, very rare. Generally, as you said, if it's anything 6 centimeters or larger, we always suspect it to be a malignancy. And anything that is 10 centimeters or larger, we always go and do an open adrenal, even though we have the laparoscopic armamentarium with us. When you said it is benign, isn't it? You said it's a cortical adenoma. When will is that a definitive diagnosis? Or do we want to do anything else with regards to prognosis for the patient, follow-up of the patient?
So for further management, like we'll call the patient about 6 weeks later, and then again maybe see if there's any.
Okay, quick question. How long would you like to follow up the patient?
About 2 to 3 months at least.
You would like to follow the patient for her life, because even if pathologically they say that it's an adenoma, it can still be a a misrepresentative report. It can still metastasize at a later date. So anybody with such a large tumor is on follow-up for her life, right?
Thank you, sir.
Interesting, very interesting. Thank you.
Thank you, sir.
Thank you.
Thank you, Vandana.
We have
Next, we
Prasanth.
come to the fourth poster. Annular pancreas. We know it's very common in childhood, but in adulthood, annular pancreas is surprising. More surprising is the simple. So the poster will be discussed by Dr. Sai Prasanth. You want to speak, Dr. Sai?
Good evening.
Good evening.
My topic for today is to discuss regarding a case of pancreatic anomaly, which is rarely seen in adults. He is a 41-year-old male, resident of Bangalore, daily laborer by occupation, presented to our emergency department with a chief complaint of upper abdominal pain on and off since 15 days, associated with vomiting 2 to 3 episodes per day containing food particles since 15 days. He is a diabetic patient and a known alcoholic and a smoker. On examination, vitals are stable, abdomen was soft, fullness noted in the epigastric region, and diffuse tenderness was present. Bowel sounds are sluggish. One rectal examination was normal, and other systemic examination was normal. Chest X-ray and abdominal X-ray was done, which showed a prominent gastric fundal shadow. Patient was subjected to CECT abdominal pelvis, which showed dilated stomach and a complete obstruction at the level of second part of the duodenum, indicating the diagnosis as annular pancreas. Upper GI endoscopy was done, which showed the same finding, that is the narrowing at the second part of the duodenum. Patient was taken up for the surgery after preoperative anesthesia checkup and informed consent. Midline laparotomy was done, and the following intraoperative findings are seen. This picture shows the dilated stomach, and here we can see that the narrowing of the duodenum over here. Patient underwent a bypass procedure, that is the gastrojejunostomy along with jejunojejunostomy. Postoperative period was uneventful, and patient was discharged on postoperative day 6. Coming to discussion, at the 5th week of gestational age, single dorsal and 2 ventral buds are formed as outgrowths of primitive foregut. At the 7th week of gestation, as we can see in the figure, the ventral bud rotates and passes behind the duodenum from right to left and fuse with the dorsal bud. This ventral bud, which rotated from the right to left, forms the inferior or part of the uncinate process along with the inferior head of the pancreas, whereas the dorsal bud forms the remaining part of the pancreas, that is the tail and the body. Annular pancreas is a congenital anomaly that results from the failure of ventral bud to rotate with duodenum, resulting in the envelopment of the duodenum. Based on the degree of envelopment of the duodenum, it can be a complete ring or a partial ring, with partial ring being the most common type. Annular pancreas is a common neonatal condition causing duodenal obstruction and is associated with other congenital anomalies like Down syndrome, intestinal atresia, etc. Annular pancreas is rarely reported in adults, with a reported incidence of 0.005 to 0.015%, in which males are more predominantly affected, with a common age group between 30 to 50 years. Cramping epigastric pain postprandial fullness, which are relieved by vomiting, seems to be the most common symptoms of annular pancreas. Annular pancreas is associated with other benign conditions such as pancreatitis, peptic ulcer disease, and gastric outlet obstruction, with most common being the pancreatitis. Its association with malignancy is rare, and a study done by Sandra Sagerson et al. Reported a 13% chance of malignancy in annular pancreas. Ultrasound and plain radiograph seems to be the first investigation done, and CECT, abdomen pelvis, and MRCP are helpful in diagnosing the patient with annular pancreas, with MRCP being the best non-invasive method. ERCP can also be used for diagnosis, but it is an invasive method. Treatment includes bypass surgeries such as duodenojejunectomy, which is commonly done in neonates, and gastrojejunectomy or duodenojejunectomy, which is done in adults. Dissection of annular pancreatic tissue is not preferred, as it is associated with severe complications like pancreatitis, pancreatic fistula formation, incomplete relief of obstruction, and lower rate of permanent cure. With these complications, the treatment of choice for annular pancreas is bypass surgery. With this, I would like to conclude by saying that although incidence of annular pancreas is very low, its presence may be suspected in cases of epigastric pain with an unusual presentation. These are my differences. Thank you.
Is open to discussion, doctor.
Yeah, very nice, Prasanth. So the patient presented with GU, is it? Gastric outlet obstruction?
Yes, sir. Gastric outlet obstruction.
How old was the patient?
He's a 45-year-old male, sir.
And what is the peak age of presentation of this annular pancreas?
Usually in the middle age, 30 to 50 years of age in adults, but it is most commonly seen in neonatal condition. It is a congenital anomaly.
Yeah, it is a congenital anomaly, but what is the peak age? Is it a pediatric presentation or is it young adults? Or you said it's 30 to 50 years, right?
Yes, sir. In adults, it is 30 to 50.
Mm-hmm.
Yes.
Okay. So did you do a laparoscopic procedure or an open procedure?
Open procedures.
Would it have been done laparoscopically?
Yes, sir. It can be done. But in our center, we did it in a lab.
Obviously, I mean, we all have our. I'm not faulting. Just asking, just for information.
Yes, yes, sir. It can be done, sir. Laparoscopy can be done.
Yeah, good case. Anybody else has any other questions?
Time is there. Half a minute more. Dr. Vandana. Yeah, no questions, miss. Thank you, Prasanth. That ends our poster number 4. Next poster. It is an abdominal abscess. Upon opening, what do you find? Surmising it, what has got Dr. Vijay will present on paper on a poster. Unusual intruder, the anterior abdominal. Over to you, Vijay.
Good evening all. I am presenting a poster about an unusual intruder in the abdominal wall after cholecystectomy. We had a 65 years male who presented with a wound over the right lower abdomen along with pus discharge. We had no fever or chills. It is a known case of diabetes as well as hyperthyroidism. Patient had a history of laparoscopic cholecystectomy for acute calculus cholecystitis in January 2021. Following a month, he was admitted for fever with chills and he was diagnosed with atelectasis. And ultrasound also showed a GB fossa collection of 7 ml, which was considered insignificant in the presence of atelectasis. After the 2 months after, the patient presented with a drain site abscess, which was removed under local anesthesia, and the wound healed well. Whereas after 2 months, he had a recurrent abscess at the same site. Hence, since it was a recurrent abscess, we took him to OT for exploration. To our surprise, we found 2 titanium clips which are used for cholecystic lap chole as a content of the abscess. Here you can see in the images, the 2 titanium clips present. And a sinus tract was seen extending into the abdomen. And on passing the feeding tube, around 15 centimeter length was to be found. This is the post-op X-ray taken along with the feeding tube in situ. You can see the tract as well as 2 clips in the tract. And wash was given using the feeding tube and it was removed after 2 days. The wound has healed well without any recurrence till date. Coming to the discussion, lap chole is such a common procedure and it's a very invasive procedure of choice for gallbladder removal. And surgical metallic clips are very commonly used in this. And these clips are made up of inertial materials such as titanium. Since the complication due to these clips are very rare, and these include clip embolism or migration or biliary leak, which could be potentially fatal. To discuss our case, surgical clip migration is mechanism of this is very unclear. Some of the factors which could influence are the placement of the clip, the use of the number of clips used, as well as the indications of cholecystectomy, like in acute inflammatory settings such as cholecystitis or pancreatitis. The dense adhesions and inflammations will distort the anatomy and which increase the risk of migration. So how to avoid this? Ideally, only 2 clips should be left behind, and practicing using absorbable clips, whereas clip migration has also been reported with these absorbable clips. And the best is clipless cholecystectomy using a harmonic scalpel, which is effective and safe, and it has got very fewer complications as well as short operation time. Coming to the conclusion, lap chole is such a common procedure that even a rare complication will affect a significant number of patients. And there are so many case reports where a slipped gallstone has presented as a recurrent abdominal wall abscess. But very rare number of case reports are seen where a slipped clip or a dislodged clip presents as an abdominal wall abscess. Hence, every attempt should be made to retrieve this dislodged clip at the time of surgery to prevent this complication. And we should try to practice leaving behind only 2 clips or using absorbable clips or following clipless cholecystectomy. These are my references. Thank you.
Yeah, interesting case, Vijay.
Thank you, sir.
You said clipless cholecystectomy, right?
Yes, sir.
With the use of energy sources.
Yes, sir.
Can you provide us any references on that? Anybody who's doing it? Any numbers?
In our institute, we have not practiced it, sir. But there are some reports where for Western countries where they are following this surgery.
And they're not having any problems with it.
As per the case reports, they are not having over a follow-up around 2 to 3 years. They have followed those cases.
Okay, so
they have not reported any.
I suppose you've assisted your fair share of lab colis.
Yes, sir.
Which year are you? Second year, third year, first year?
Second year.
Second year. Okay. So if you have assisted your lab colis, obviously we use our energy sources.
Yes, sir.
And what all do we clip?
We'll clip the artery, cystic artery, and the cystic duct, sir.
Okay.
While using energy sources, we'll not clip arteries.
Okay, so you don't clip the arteries with the energy source. Why would that be?
Because with harmonic, that should be sufficient to cause the hemostasis rather than using an extra clip for the artery.
Okay, so you're not using the clip for the artery. That's what
Yes,
you said, right? So harmonic itself should be enough for the artery.
Should be enough.
What about the cystic duct?
Cystic duct in our institute, we use only 2 clips to like cystic duct.
Right. So suppose you did as per the journal and as per your practice. I mean, you put it up, clipless cholecystectomy. Suppose you went and did it. You used harmonic for the cystic duct. What do you think could happen?
There will be a slight risk of leakage, sir.
Why would it leak?
Because if at all if any case has got any cholecystitis features, the duct might be friable where it could leak in future. Post-op.
Okay, let me tell you what happens. Once it's happened many times when we've used energy sources in the dissection of the callous triangle, and then let us say the patient has a little bit of a collection post-operatively, presenting acute or presenting at a much later date. See, there can be energy source induced heat injury for the biliary apparatus, the biliary system, and the hepatic duct, right?
Yes, sir.
So suppose there is heat injury, we do not recognize it on table because there is no bile leak on table. But part of the wall might have got sloughed out. Part of the wall might have got necrotic. It might not slough out in front of your eyes, but it will slough out over a period of 48 to 72 hours. And then there will be a bile leak. You will not identify it on table, but there may be a post-operative bile leak, which is the reason why biliary ducts are not dealt with energy sources. Securing of biliary ducts is always with mechanical tamponade, be it a hemolock or a clip or whatever. Okay, this patient had a titanium clip which caused the abscess,
Yes,
isn't it?
yes, sir.
Where do you think there might have been a breach in antisepsis?
Where to look in the past history, where the patient presented after a month with fever and chills, and GB force has shown a small collection. There, in the presence of cholecystitis, the clips might have migrated, sir.
Okay,
Or they
so
would
in
have
presence
slipped
of
in the presence of
cholecystitis, the
collection.
clips might have migrated. So the infection from the gallbladder might have gone
From the
on to the
gallbladder.
inanimate clips.
Yes, sir. Though they might have stained the clip, which has acted as a nidus of infection.
Another possibility is that we will have to look at the sterilization, the way things are sterilized. There may be an antiseptic breach over there, right?
Yes, sir.
This is important because it could have medico-legal implications. We need to tell the patient this, and of course, we need to check.
Time is getting.
Thank you. Thank you very much.
Thank you. Thank you, Dr. Vijay. Now, the last poster would be by Dr. Nida. It is about the thoracic thoracoscopic repair of congenital abdominal. In fact, over to you, Nida.
Yeah, Dr. Nida, hi. Go ahead.
Thank you, sir. Just a second. Good evening. Today I'll be talking about a patient who came, a newborn child with CDH, who we operated thoracoscopically. This was a late preterm baby, 36 weeks, delivered by LSCS. Birth weight was around 2.4 kgs. For this child, the ANC scan was done, showed an over-distended bowel and a mild cardiac shift. The child had a good ABGAR score. The mother had a history of hypothyroidism. On day 2 of life, the baby had respiratory distress and was hence intubated. Chest X-ray was done, showing a left CDH with bowel herniation into the left hemithorax and shift of the cardiac. Echo was done, which was shown to be normal. This is the pre-operative X-ray of the child, showing herniated bowel into the left thoracic hemithorax. On day 3 of life, patient underwent thoracoscopic
Dr. Nida, please stop.
Yes.
Stop. I think there's some other speaker who's unmuted.
Yes.
Vijay Hospital, that is what is visible on the screen.
2 days.
Vijay Hospital, yeah, thanks. Thanks for muting. Yeah, go ahead.
On day 2 of life, patient was taken up for surgery. As you can see, this is a marking. The infrascapular region, one port was put along with the anterior and posterior mid-axillary line. There were 2 other ports placed. This is the defect, as you can see. This is a video of us reducing the contents of the hernia. Post that, we got the defect, which we hence have approximated. And this is post suturing. Post-op picture, you can see that the shift of the cardia is back to its normal position on the left. The stomach and the intestines are back in its abdominal cavity. Post-operatively, the patient was in the NICU. The child was extubated on POD4 and oxygen was stopped on POD6. ICD, which we had placed, was removed on POD5. Patient was maintaining saturation on room air on discharge. Follow-up, the child is now around 6 months, has no complaints, is feeding well, there's adequate weight gain as well. The discussion for this, the main reason I presented this paper is usually a CDH that is seen in around 2.6 per 1,000 live births. We tend to do it by a laparotomy procedure. But since this patient was hemodynamically stable, he did not have any cardiac anomaly, we decided to go ahead with a thoracoscopic repair. The advantage of this was thoracoscopically, post-operatively, we can start the feed sooner as there will be lesser ES, and the patient will also have a smaller scar. These are my references. Thank you.
very interesting case. Any idea how many such laparoscopic thoracoscopic repairs have been done?
This was our first, sir.
This was your first. Many
Yes.
congratulations to your team.
Thank you, sir.
And many congratulations to the anesthesia team as well.
Definitely, sir.
They
Definitely.
deserve as much credit as the pediatric surgeons.
Hima, can I ask few questions?
Please,
You
please,
have
please.
time.
Please.
Nida, congratulations to the pediatric surgical team. Is it the Vinay? Dr. Vinay did it?
Yes, sir. Yes, I did.
Okay, he's my very close friend. Was there any pulmonary hypertension?
No, sir. We had gotten an echo and everything done. There was no PAH.
Did you see the lung inside?
There was, the lung was hypoplastic, sir.
So when does it expand? Post-op?
So by around day 2 or day 3, it should tend to expand, which is why we had put
I
the-
don't think so. It'll take 6 months. It's
Oh.
okay. It's hypoplastic. So you should be careful about the pulmonary hypertension
Yes, sir.
and the hypoplastic lung.
Okay, sir.
And there is a plenty of bad prognosis in CDH. Don't
Yes,
think
sir.
caller will have a, what do you call that, honeymoon period. There is a honeymoon period in CDH. Very
Okay.
bad, especially antenatally detected. There are plenty of prognostic factor, and this
Yes,
is not
sir,
the
yes.
form. Thank you.
Thank you so much.
Yeah, Venki sir, it is actually when I saw your questions, it is very heartening to know that I still have a little bit of a connect with pediatric surgery.
Yeah, thank you, Hima.
15 years after having stopped studying pediatric surgery.
Yeah, you can join us academically.
I don't mind doing 2 MCHs.
Yeah, thank you. Yeah.
Anyway, that was the question on my mind too, because a lot of it is said that surgery is just one incident in the process of rehabilitation and treatment of a patient with a congenital diaphragmatic hernia.
And
Because the
take home
main
message
issue-
for the surgical postgraduates is it is not a surgical emergency.
Yes,
It's
yes.
a medical
Medical
emergency. We'll have to stabilize the patient, then only shift the baby to OT. Okay.
Yes, sir.
And there's a lot of post-operative rehabilitation also involved because of the
Yeah.
hypoplasia.
Yeah.
Yeah, wonderful.
Thank you.
Thank you.
Thank you so much.
Thank you, Dr. Nida. That ends our poster session for the day. Thank you, Dr. Hima for the conducting and being.
Always a pleasure, sir. Thank you.
Thank you, sir.